So, good morning, everybody. Good morning, and thank you for thinking it not robbery for coming out. My name is Laverne Crowder, and I'm the founder of the Optic Neuritis Foundation. And this is our 5th educational event with the MS Center of Atlanta, and we're excited about it. So, without further ado, I wanted to introduce our moderator, and we can go ahead and get started. Mr. Horace Derricott. He has some announcements. Also, if you guys can mute your phones, please, because we are recording. If you need anything, Claire and I will be on the side and in the back. Just let one of us know. And I hope you have a good time. Thank you for coming out.
Good morning, everybody. How's everybody this morning? Let's kind of get some energy going in here because it's kind of dead. So let's kind of just get a warm-up clap. Thanks for clapping for me. I appreciate it. I want to again thank the Optic Neuritis Foundation and the MS Center for presenting this educational seminar today. So without further ado, we'll get started. We have two very distinguished gentlemen serving on the panel today, Dr. Doug Stuart to the far left, and Dr. Kannan Narayana. Dr. Stuart is a clinical neurologist in Atlanta, Georgia, and has been practicing for 25 years. He graduated from Emory University School of Medicine in 1988 and specializes in clinical neurology and MS. Our next panelist is Dr. Kannan Narayana. He joined Emory Eye Center in July 2015 as an assistant professor in the neuro-ophthalmology service. He completed his neurology residence at Rutgers Robert Wood Johnson Medical Center in New Jersey, and is also a recent fellowship in neuro-ophthalmology at NYU School of Medicine. He also has a primary practice at Emory Hospital, Midtown. The format for the seminar today is going to be quite interactive. We have a couple of videos from both of our panelists, and then I have some questions, and then I want to open it for you all to have questions. And trust me, if you don't have any questions, I'm going to ask all of my questions. But I think I want to hear some of your questions. So without any further ado, we'll start with Dr. Stuart.
Thank you, Horace. I appreciate the opportunity to speak to you all this morning. I recognize a lot of faces in the audience, and some are new, so I appreciate you spending a Saturday morning learning about MS and learning about optic neuritis. We've been privileged really to work in this field now I've worked in MS my entire career, and I've been able to see quite a lot of very exciting advances in the way that we look at this disease, the way we treat this disease, and really an evolution from no drugs to now over a dozen medications that are effective and safe and fundamental in the way we treat multiple sclerosis. And I think it's really changed the outlook for people who have this disease. But what I usually like to do is to start all of our talks sort of with an overview of what MS is and how we make the diagnosis, what are some of the symptoms that people with MS experience. Not that any of this is new to many of you in the room, but to kind of frame up our conversation around optic neuritis, which is certainly the most common of the MS exacerbations, and Dr. Narayana is going to speak in great detail about some of the principles around treating the eye with multiple sclerosis. But I want to give you kind of the big picture around how we at our center treat MS. So I put together a few slides last night. Collins, if you could move us forward, just to kind of frame up some of the issues, and we'll be talking a little bit about the signs and symptoms of MS, some of the ways in which this disease we feel comes to be, and then I'll show you a couple of MRIs that can give you kind of an idea about what MS looks like to us as neurologists, and then we'll talk a bit about management and prognosis. Next. So first, what you need to know is that for a neurologist, this is a very common disease. This is actually our most common disabling illness in young adults if you take away trauma. So the most common thing would be car accidents and falls and that sort of thing. But if you take trauma away, this is the number one thing that brings disability to young adults. It's very common. I think most of you, certainly apart from having the illness yourselves, know friends who have been affected by multiple sclerosis. We used to think it was about 1 in 1,000 people. It's really probably more like 1 in 600, 1 in 700 people, depending on where you live, There are areas of the world where it's more common and other areas where it's less common. It typically begins in your 20s and 30s, although there are children who develop multiple sclerosis, and then there are older adults who develop MS. Although in retrospect, many of our older patients probably have had the disease without knowing it for many years. It's twice as frequent in women as men. We don't exactly know why that is, but for some reason there are 2 times as many female patients as male patients. It tends to be more frequent in patients who live further away from the equator. So we see this disease more commonly in countries that are, let's say, Northern Europe, Canada, Great Britain, that kind of thing, and less so in Central America, Africa, tropical climates. It is more common in patients who have family members who are affected by the disease. So autoimmune diseases tend to run together, and if you have a family member who has an autoimmune disease, MS or sometimes some other autoimmune disease like lupus or rheumatoid arthritis or psoriasis, the incidence of MS goes significantly up. And so we see upwards of a 7-fold to 10-fold increase in the incidence of MS if you have MS in the family. Next. There are many symptoms of MS. MS can affect pretty much anything that the central nervous system does. So, and that's pretty much anything that we do. So we see symptoms of visual impairment, we see symptoms of cognitive changes and mood changes. Depression is very common. Fatigue is probably the most common thing we see in multiple sclerosis. But we certainly also see the things that you as lay people would associate with MS, such as walking problems, difficulty getting around, needing a cane or a walker or even a wheelchair to get around. Pain syndromes are common in multiple sclerosis, loss of sensation, loss of balance, even loss of bowel and bladder function. These are all things that are very common in multiple sclerosis, and they occur randomly, so that each and every patient may have a different combination of these symptoms, which may come and go, or which may come and stay. And so there really are no 2 MS patients who look identical. Each patient has their own sort of pattern of MS, and that's what keeps us on our toes as neurologists, is trying to figure out what are all the things that we can help with medication or with physical therapy or with disease-modifying agents. Next. Now, if you've ever been to an MS talk that I've given or that most of us give, you'll recognize this slide. And this is a picture of an iceberg. And I call it the MS iceberg because I've never really seen an MS talk that didn't bring this point up. But the point of this slide is that what you see in MS is just the tip of the iceberg. So icebergs, as you know, have maybe 1/5 of their mass above the water, but 4/5 of the iceberg is below the water and you can't see it. And the same holds true for multiple sclerosis. So the things that people can see about you and your disease would be, your cane or your walker or your wheelchair. I mean, these are visible outward signs of disability. But the disease is so much more. And that's really one of the things that makes this a difficult disease in terms of understanding, having the community that can get behind you and understand where you need help, because the majority of what MS does is under the surface. It's the other part of the iceberg, and that can be cognitive changes and fatigue and pain, bowel and bladder changes. So all the stuff we were talking about before, most people are never going to see that in you. And yet, those may be the principal reasons that you're disabled, that you have challenges at work or challenges in your relationships at home or with your family or friends. So the MS iceberg is really a very daunting problem because we have to treat what's above the surface and below the surface, and we can't ignore either side. And it goes beyond that because even biologically, there are things that are above the surface and below the surface. So as a neurologist looking at you, there are things I can pick up on a physical examination, but there's a lot that's happening biologically that's microscopic and that's immunologic and biochemical that you don't really see. You don't even see it on an MRI. An MRI will only show about half of what's going on with your disease. That's why patients will come to me and they're clearly doing worse, and we get a scan and there's no change from the last scan. But they clearly are walking slower or thinking slower or having more pain. And they ask me, well, how can this be if you can't see it on an MRI? And the point is that much of what this disease does is not overtly visible on either imaging studies or sometimes even blood work. So anyway, I like to make this point to all of the groups that I speak to because it speaks to the largeness of the problem that this disease brings to us. Next. These slides didn't come through very well. Shows that I'm not much of an audiovisual aficionado, but I did want to speak to a couple of things. One is causes of MS. So people ask me, what causes MS? And the answer is we don't really know all of the things that cause MS, but we know there are three things that are associated with MS. One is, as we referenced earlier, genetics. So there's a genetic risk that we believe is at play in causing multiple sclerosis. But it doesn't seem that it's just the genetics, otherwise everybody in a family would presumably be at risk. It seems that there are probably geographic factors, where you grew up, what you've been exposed to growing up, and possibly even infections that you've come into contact with growing up. So the three things that we commonly are looking into in research studies to try to sort out where MS comes from include the genetic factors, potential infectious exposures, and then environmental exposures, where you grow up, where you work, those sorts of things. Now, the pathology of the disease is complex. It appears that there is a complex dysregulation of the immune system. This is an autoimmune disease, where the immune system that we rely on to fight off infection and fight off malignancy, for whatever reason, starts to misrecognize our myelin, which is a protein that surrounds nerve cells, and perceive it as though it is an infection that it needs to kill. And so the immune system becomes out of regulation, or what we call dysregulated, and that can lead to two things. The most important thing that we see is something called inflammation. And we're used to inflammation in other terms because it's important. Inflammation is what we use to fight off infections or to heal tissue from injury. But when inflammation is turned on yourself, it can cause tissue damage, and that's what causes the lesions of multiple sclerosis. But beyond that, and perhaps more troubling, is something called degeneration. So degeneration is not inflammatory. It's just a dying off of normal tissues. In this case, it's a dying off of nerve tissues. And it's much harder to treat. We don't really have any drugs that we know address degeneration, and yet degeneration seems to be the logical end game of inflammation. So a lot of our drugs, all of our drugs presently, are designed to reduce inflammation. But we feel that if you can address inflammation early, you can prevent degeneration. So inflammation and degeneration go together. We presently have many good drugs to address inflammation, but we don't have any good drugs to address degeneration. But we hope that if we can get to the inflammatory part of the disease early, we can prevent the degenerative part of the disease that usually occurs later. Next. Okay. I like to bring a few slides. Just, I always say a picture is worth 1,000 words. We talk about lesions in MS, and this is a picture that shows some of the typical lesions of MS. And this is what MS looks like. Most of you who have MS are familiar with looking at your own MRI. But just to show you these white spots that you see, this is a slice of the brain, and the white spots that you see are all scars. They're areas where the brain has been scarred from inflammation that attacks the myelin of the brain. And it leaves these scars which proliferate, and over time you get more and more scars and more disability. The second slide is a picture of the spinal cord. MS likes to affect three areas: the brain, the spinal cord, and then, as we'll hear, the optic nerve. So this is a picture of the spinal cord. You can see those arrows showing little white ovals that are also scars in the spinal cord, which can be very disabling, affecting your walking, your balance, your bowel and bladder. Next. And then this is a picture of the optic nerve, which we'll get to, and I don't want to steal Dr. Narayana's thunder, but this is the third area that demyelination likes to get to, and we'll hear much more about this in a few minutes. Next. And next. Dr. Narayana's he's got his own slides that show exactly these issues. This is a picture of the microscopic pathology of MS. And on the left side of this slide, you'll see a typical healthy nerve cell where the top part is the cell body, and then on the bottom part you see this long tentacle that we call an axon. And an axon is the wire that connects one nerve to another, and it allows electrical activity to move from one part of the nervous system to another part of the body. And that's really how our brain, which is our computer, drives our arms and our legs and our eyes and all of our bodily functions. They're driven by electrical activity that travels down axons. But axons require this yellow substance called myelin. You can see the myelin sheath surrounding the axon. Well, just like the wire surrounds a telephone cord or an electrical wire. It insulates that wire so that it stays healthy, it stays intact, and it allows the electricity to travel much further distances than it would be able to otherwise. On the right side of the slide, you see on the top healthy myelin. It's a nice thick coating around the axon. But when it's damaged, you see that it gets frayed and the axon becomes exposed, and it's no longer functional, and the electrical message gets lost. It can't get from point A to point B, and depending on what part of the nervous system has been affected, you will lose that function. You may lose vision if it's the eye. You may lose your ability to walk if it's the spinal cord. You may lose changes to your bladder. You may lose sensation. There's all manner of symptoms that these areas of demyelination can cause. Next. To let you know just how complex the biology is, that demyelination is regulated by all of these different cell types. These are a bunch of different white blood cells and the various chemicals that drive them. And this is in our world, the tip of our iceberg. So there are a lot more cofactors that are involved in driving this very complicated immunologic disease. And our drugs that we use get into areas that kind of disrupt this sort of sequence of events. You see areas where interferons or glutamer or natalizumab or tecfidera or a variety of different drugs can disrupt this immunologic cascade and bring some regulation back to the system. Next. The diagnosis of MS is sometimes easy, sometimes difficult, but it usually rests on an appropriate clinical history of neurologic disability. And then we suspect MS, but we prove it by getting an MRI, getting a spinal tap, or checking blood work for any of the other diseases that sometimes can mimic MS. That's why my last line here is exclude other causes, because not all that looks like MS is MS. And we have to be absolutely sure that we're treating the right thing before we embark on one of our medications that we use to challenge the immune system and oftentimes to suppress the immune system. So you have to be sure what you're treating, and the journey to that diagnosis is sometimes easy, but sometimes quite challenging. And every day we see patients who've had a very hard diagnosis. They've often seen a number of different doctors who've told them they have psychiatric illness or have stroke or have migraine or have some other thing, when in reality they have multiple sclerosis. And so it is a challenge, but a diagnosis usually can be rendered if you really listen to the patient and you do the right studies. Next. MS can take many different forms. Some people have the so-called relapsing remitting form, which is the most common form, where you get an attack and then you recover, and then you may be fine for months or even years. I've had patients go 20 years before their second attack. But then there are other patients who progress from the get-go. They really don't have attacks, they just steadily get worse. We call this primary progressive. And then there are variations in between. There are patients who start off with relapses and end up with progression, or some patients who just have terrible relapses from the get-go and they progress very rapidly. Next. The management of MS really revolves around three things. First is treating attacks when they occur, and that's largely done with steroids or some type of steroid medication. The second is trying to address the fundamental biology of the disease, trying to change your immune system so that you're less prone to attacks. So steroids we give you after an attack occurs, but disease-modifying therapies we give you before attacks to try to prevent that attack from ever occurring. And then, you know, if there are symptoms that have kind of developed that have challenged you, like spasticity or pain or urinary problems or fatigue, we have medicines to treat these specific symptoms, and we call that symptomatic management. Next. What does MS look like in the long term? Well, the prognosis is quite variable. I told you earlier that no two patients really look quite alike, and the prognosis runs a very broad spectrum. It's not like cancer where you know where cancer typically ends. MS can do very well, or it can do very poorly, or sometimes it can be in the middle with some disabilities, but not terrible disability. And so it's a variable prognosis, but we do know that treated patients do better than untreated patients, and that's why the tone of our conversations in the clinic usually center around making sure that you are on an effective therapy that works for you and that you can tolerate and that is impacting your disease in a favorable way. We know that meds work. It is a very uncommon situation where I would have a patient with MS and I would say, "You're so good, I don't think you need medicine at all." That doesn't happen very often, but it does happen once in a while. Wellness issues I've just thrown in there to kind of emphasize the fact that apart from these very sort of complicated and sometimes very expensive therapies, there are simple things you can do to improve your prognosis with MS as well. And they revolve around the kind of stuff that helps everything in your general health and well-being. It's weight control, eating the right thing, having a healthy diet, and exercise. And then managing stress, I think, is another thing that I didn't throw up there, but stress management is very important, I think, in improving your overall quality of life, and I think your long-term prospect of dealing with this disease. That's all I have for you, but so I throw that up to kind of to tee off the discussion. I hope we'll have some very good questions generated here, but these are the issues that as an MS neurologist I'm looking at every day in my clinic. And from here I'd like to throw it over to Dr. Narayana to talk specifically about optic neuritis.
Good morning, everyone. I'm Kannan Narayana, and thank you so much for having me here. It's a pleasure and privilege, and I'm very happy and proud to have my family here. My parents are here, as well as my two boys, my wife, and I'm very grateful for the opportunity. So I just wanted to highlight a couple of things that Dr. Stuart was already mentioning. I think that one is that MS is a multifactorial kind of problem, one of the classic examples. What we mean by that is there are so many things. The iceberg example that he was showing is kind of phenomenal. It's very important in the sense that there are so many factors that go into this disease, and therefore it is very difficult to comprehend just based off of an MRI. And in fact, the diagnosis is primarily clinical, and so it's basically what the patient is saying. So I keep stressing this to all our residents and medical students. The most important, somebody comes in and they want to present a case to me, they're saying, first thing they'll tell me is the MRI was already done and it's negative. And I say, hold on, take a breath and tell me, first thing is, what is the patient saying, what they are here for? That's the most important thing, right? So here, two things. One is the inflammation aspect. I just wanted to highlight when we say inflammation and autoimmunity, what are we meaning by that? So I always try to make it very simple for the patients because sometimes things are very overwhelming. The third slide, for example, that slide is challenging even for neurologists. It's not easy. What are you showing? The molecular slide, etc. Right, but in terms of the immunity, we do have a defense system in our body that's working at an optimal level. Let's say it is this level. Like just like the blood pressure can fluctuate, it can fluctuate a little bit. And if the defense system is not working well, then you get external attacks from the organisms, which could be the bugs, the bacteria, the viruses, the fungi, for example, and you get an infection. If your system for whatever reason is overacting, that means it is ready to attack and it has to attack something. And when it starts attacking your own tissues, then it is called auto, which means self-inflammation. Right? That's what an autoimmune disease means. So that's just one idea. Right? There are other factors which he was highlighting. One of them is the role of vitamin D, for example. Relating to the sunlight and vitamin D, it's thought to be one of the important. That's also becoming important with the optic nerve function. Patients with low vitamin D levels, they are finding that their recovery and the severity of the vision loss might be a little higher. So the role of the micronutrients or the nutrition is quite important in these neurological disorders. Similarly, environmental factors, for example, there are papers from the US. People who migrated to the US before the age 35 have a little increased risk of developing MS. If you migrate after age 35, you may not get MS even if you live in the US forever after that. The other thing is when we don't see MRI problem and patients have a lot of symptoms, and I just wanted to highlight a couple of other areas. One is that with wear and tear of the body, for example, once you turn 35 or 40, there is normal wear and tear just like a car. And we may not even recognize it, or we may just feel a little pain and we just walk with that's normal life. But if you have a disease that's affecting the nervous system, maybe there is microchemical imbalance and you start feeling them a little more. We use the word in neurology which is called hypervigilance for these type of things. So the awareness of these small problems that might be more bothersome to the patient. So this is real. So it's all microchemical. Patients are, the way this helps is, it's good thing somebody is not having an exacerbation right now, but if they're feeling these symptoms, you enable and the patient understands much better and they are more comfortable dealing with that problem. So that's how I think about that. And so mentioning those things about MS, so let's get into the, I don't think we have a pointer here. So if you go back to the prior slide, please, the previous one. Yeah, so how many of you think we see from the eyes? Please raise your hands. You see the world with your eyes. Correct statement or wrong statement? Say that again. Correct. How many of you think we see from the brain?
Correct.
There's 50-50. Well, both are correct actually. Okay. So this is the whole landscape of the visual system. So the vision happens in the back of the brain. So this is where we see from. It's in this area. So we are seeing from here. So that's the occipital cortex, right? And so the vision starts in the front. So the camera that's continuously taking pictures of the world is the eyeball. So now if you look at it, the eye is a very small organ right in the front and it's taking the pictures. Now, the front part, the ophthalmologists see, the eye doctors see, or the optometrists see, what they are doing mostly is to focus the rays onto the film in the back of the eye. So if you just show that part, back of the eye, where there is the red line, like the cup like that, right? That is called the retina. It's just, you can imagine like a film in a camera, it's taking pictures. Now if the focus is not good enough, right, the quality of the vision is not good. So you got to focus well. So zooming in and out, getting the best lens possible is the job of the glasses and the contact lenses, etc. Right? If you have dryness, your quality can degrade. So if you put drops, your quality can improve. So the front part has to do mostly with the focusing. Now the nervous part of the vision starts in the retina. So the retina is a complicated film. It's got 10 molecular layers. And there are diseases in the retina itself. That's why you have a specialist by name retina specialist. But from then on, you have the optic nerve. An optic nerve, we are only able to see the face of the nerve inside the eye. So it's a 5 centimeter structure. You're seeing 1 millimeter inside the eye. So we're making a lot of assumption by looking at a 1 millimeter inside the eye. So you can imagine that eye doctor examining, looking at the nerve could be wrong because there could be some other problem behind the eyeball, right? So the only way to see the nerve behind the eyeball is getting an MRI, right? And then so on. So then there is a crossing. So if you see that X part, the middle, yeah, right there. That is the area below which there is a gland called pituitary gland. So if you have pituitary tumor, it can push on both the nerves and you can have problems that way. If you have a stroke in the back part, it can affect the vision. So the back part is divided this way. So if you draw a line in the middle, this part of the world is seen by the left side of the brain and left side is seen by the right side. So it is a complicated circuitry. Just by thinking through this, it is complicated. And so the problems in MS most commonly, I'm only saying most commonly, it can be in other parts, is in the optic nerve. So now we get an idea. So let's go to the next one. This is a real kind of cartoon. It's pretty decent picture. So this is the real brain. And if you move the brain to the side, that is the neural pathway. So here is the eyeball, right? And then that's the optic nerve. This occupies about 50% of the brain tissue roughly. So in other words, if you have brain disorders, the chance that your vision is affected is very high, extremely high. All right, so let's go to the next slide, please. Here. So this is the picture of the eye itself. And so a lot of questions come up about other type of symptoms, discomfort in the eye, to actually vision issues. And so as I was saying, in the medical knowledge, the kind of research, we are able to replace this structure, which is called the cornea. It's like the glass on the top of a watch. It's just a clear structure. If that becomes opaque from any disease, which is called the cornea, they can take it out and put a new one, right? Similarly, this is called the lens. This lens can be taken out, put a new one. That's called the cataract. You can change the focus. These, both of them, just by physics, they act as lenses. They focus the light. So the glasses in front or the contact lenses, they're all helping focus. The retina and optic nerve, we can talk about the research based on the questions. We're still not there yet. But there is a lot of advancement, and ophthalmology is one of the very advanced fields in terms of how they can change the entire structure. Not the whole eyeball, but they can replace parts extremely well. Okay? So when we talk about the optic nerve, it starts here, and we talked about the 5 centimeters. When we say optic neuritis, we are talking about the inflammation in that part. Now, the optic nerve itself does not have any pain fibers. So when you get a pain from optic neuritis, it's kind of irritating the adjacent structures, and that's what is causing the pain. So once the inflammation goes away in a few weeks, you shouldn't have a pain ongoing from this problem. Okay? So those are some of the basics of the optic neuritis, and probably we'll be able to do much better. By the way, if I looked at some of the questions that some of the patients had, I think it will be very nice to discuss through the questions.
Okay, any questions from the floor before I start?
I do have a question regarding the optic part of it. Optic neuritis is what is affecting the eyes. And pains in the eyes from the MS is due to whatever issues you have with the optic neuritis. Yeah.
Right. So in MS, the most common problem that happens is what is called the optic neuritis. So whenever you hear the word itis, I-T-I-S, for example, appendicitis, tonsillitis, it means there is inflammation in that structure. Right? So we are saying the optic nerve is inflamed. It's in the front tip of the nerve in about 1/3 of patients. It's behind the eyeball in about 2/3 of patients. So you might have heard of terms like retrobulbar optic neuritis, and in the back part. That is not seen. So if you go to an eye doctor, they look at the nerve looks normal. That's because it's behind. Okay? And so that's the most common problem that we see in MS patients. Does that answer your question?
No, I want to know, you can have pain in your eye for a long time, or if not, maybe on a steady basis, but it can come and go.
Not from optic neuritis. That's what we were saying. It's most from the MS, I'm saying. There are other types of optic neuritis which can be long term, but from the MS, typically it's only a few weeks. It's a good thing from patient perspective. So usually when the inflammation, acute inflammation goes away, the pain goes away. If you continue to have problems, then you got to look at other possibilities, or is it really MS related or something else is going on. So it has to be assessed that way. There are lots of other causes of pain in the eye that need to be assessed as well.
Okay, I don't know if this is also related to it. There's a procedure that can be done where they can do an examination in your eye or do some procedure and you don't no longer have to wear glasses. Excuse me for the interruption, sir. Is that, and they said we cannot do that because we have MS.
So that procedure is to change the focus in the front part, if that's the question you're asking. Is it to so that you don't have to wear glasses? Right. So that's to do with the front part, or the shape of the cornea. You, by doing lasers, you can change the shape of the cornea in different ways. That's called LASIK, L-A-S-I-K, right? And that can be done. And I cannot speak for any specific patient. You know, obviously this is a general gathering, but I would say that it has to be valued, like, evaluate that particular patient needs to be evaluated. I'm not sure why exactly it was a contraindication. I can't answer that specific question for a patient, but if the vision is good, it should still be doable. There might be other reasons.
Okay, because they just said, you have MS, you have MS. I said, yes. He said, we cannot do that procedure on you. And I don't know why. And when we started speaking about the optic neuritis, I thought it was a perfect opportunity to ask.
Yeah, absolutely. No, thank you for asking that question. I think that certainly, individual cases need to be evaluated absolutely by experts. Yeah.
But that
I don't think that itself, that alone should be a problem. Yeah.
No, I would agree.
Yeah,
And this actually comes up quite frequently in my clinic as well. There's a misunderstanding, I think, sometimes in the ophthalmologist's office about what can and can't be done. MS doesn't mean you can't. Having MS doesn't preclude having an operation on the eye. There is no contraindication. What they don't want to do is to do an eye operation to improve the focus when your vision problem isn't from the focus, it's from the nerve. And so there are two ways your vision can be blurred. It can either be blurred because the focus is out of focus, or because the nerve that carries the message from the eye to the brain isn't working.
Right.
That LASIK will not fix a blurry nerve, and it's pointless to do that operation. But if it's a focus problem, LASIK will work just as well in an MS patient as in a non-MS patient. Now you can know that if you can correct the vision with glasses, you can correct it with LASIK. So I mean, they're the same. LASIK is just glasses without glasses.
Yeah.
But optic neuritis is something different. It's a transfer. It's a wire that doesn't work. And so, I think if an eye doctor knows what he's talking about and he says, LASIK is not for you, what he's saying is your problem isn't with focus, it's with transmission.
Not a problem. Yeah, that's right. Yeah.
Hello, my question is for Dr. Stuart. In your presentation, you mentioned that there are diseases that mimic MS. As I was going through the checklist, I was like, okay. My question is, what are those diseases, and who should be your first contact, your primary care physician, or do you immediately need to go to a specialist?
Well, so generally speaking, I really think for anything medical, your primary care doctor is sort of the gatekeeper. A good primary care physician knows what they know and they know what they don't, and if they get a sense that it's a neurologic problem that needs, a thorough neurologic evaluation, they're going to send you to a neurologist. But I think I like to funnel most everything except acute chest pain, to my family doctor. That said, there are a number of diseases that look like MS and cause all the things we talked about, weakness, numbness, eye pain, vision loss, depression, you name it. The short list is other autoimmune diseases like lupus, sarcoidosis, Sjogren's syndrome. Okay, these are three very, they're not as common as MS, but they're pretty common immunologic diseases. And then there are other things like stroke can often look like this. Brain tumors can mimic MS. Migraine headaches can sometimes give you stroke-like symptoms that mimic stroke and mimic MS. There are other, in optic neuritis, there are other eye diseases that can look like MS, but they're not optic neuritis. And so what we typically do is we do all those tests like MRI and spinal tap and blood work to exclude the things that look like MS but aren't MS, and then at the end of the day, if you can't find anything else and the picture, you know, is right, then that's when you make the diagnosis of MS. So, but you do need to be sure that you're not dealing with one of those other unusual things.
Yeah. One of the other common ones is B12 deficiency. That can look like MS, also can cause optic nerve problems. Easy fix, very easy fix.
So, to both of you doctors, a young lady has a question. So I just told her just to say it. You guys are not her doctors, so you wouldn't know how to address the question specifically for her. But just listen to the scenario and the situation and see if you can just help her out. Just say it.
Yes, in October, I was treated with steroids for optic neuritis, and the pain kind of, after a month, kind of left. I was treated with the steroids, but even now, it's still kind of like lingering that same pain. It hasn't went to the fuzziness yet, but like even now, the light, you know, I find myself squinting like this. So, what do you suggest I do for the pain?
Again, as you know, you're mentioning, it's very hard to give medical advice, right? And it's not scientific, it's not safe, right? So basically, in general, I would say is that question one is if the symptoms continue after improvement. Did you have good improvement before?
It did
With the
improve.
symptoms?
The symptoms, yes, they did improve, but they never completely went away from the initial attack. So it's never been completely gone anyways.
Yeah.
So I typically understand from any, you know, new issue or symptom that you can have it, then it goes away completely, and then it can come back. But in my experience, I've never had any other issues other. So it's just kind of lingering.
Yeah. So I would say these are very generic comments, not about any particular patient. So there are several scenarios. One is that I think you mentioned early on is that it's always possible, these are called the mimickers. So one can be confused with something else. So the initial data points for a specific diagnosis may have to be reconsidered when what is called atypical. If a particular problem is not behaving the way it should behave, then we have to go back and relook and see if that was the perfect and correct diagnosis. Do we have enough strong data points to make it? Now, sometimes clinicians, doctors make what is called presumptive diagnosis. It's not meeting all the data points, but it is meeting some, and they think very likely this is what it is, right? So that scenario, one scenario. The other scenario is that, is there anything else going on that needs to be assessed? So I think the best thing to do might be to have a kind of full follow-up evaluation and discussing with your provider, you know, what's going on and your concerns. And that way, sometimes they make referrals to other providers, etc., depending on what the scenario is, and then, so that might help you. That's what I think. Yeah, sure.
Let me ask a quick question. Hold on. Is there another way to treat MS and optic neuritis other than steroids? I've heard steroids quite a bit.
You want me to take it?
Yeah,
You can
you-
do it. Okay. So for optic neuritis per se, the acute treatment, right? So MS-related optic neuritis, the treatment is steroids primarily. That's the one that is accepted as the standard treatment. The MS-related optic neuritis or other typical inflammatory optic neuritis, the typical ones, when we say typical, it means it behaves in a certain way, and that's what we're discussing, right? The commonest one improves in over a few weeks, and the vision improves, and this is something that comes as a surprise to a lot of patients. So there was a large study of patients that was done in the US, and we have more than 15 years of data now, right? It's called the Optic Neuritis Treatment Trial, where a large group of patients were treated with the steroids for the first 3 days, and we have got that data, and that is where all this data is extrapolated. So the way it behaves is that the vision improves in more than 90% of the people to very great extent. Now the surprising part is the vision improves even if you don't treat. Okay? So even if you're not treated, but what the steroid does is that the speed of recovery is much faster. So the speed is one. The second advantage of the steroid is in the first 2 years, if somebody, let's say somebody gets an optic neuritis and they don't have MS, but they have a tendency to develop MS in the future. So for the first 2 years, whatever the risk is, the risk goes down for the first 2 years, but then afterwards the risk is the same. So in other words, in simple terms, it gives protection for MS development for about 2 years. So that's the second advantage. The third advantage is if somebody comes in with a severe vision loss, we may not be able to tell whether it's typical or not. In other words, we don't know if they're going to improve for sure or not. And in those cases, we certainly make the case. So if somebody has a very minimal or mild vision change and vision loss, it is probably reasonable, as long as the patient understands, not to treat. But as long as it is moderate to severe, most of the doctors and patients elect to treat. So that's about the steroid treatment. Now, if it is not behaving, or if there are examination findings that are not typical of the typical optic neuritis, then there are other treatments. For example, what we call as the plasma exchange or IVIG treatments that are used in some of these patients. So it depends on individual cases and how much is the vision loss, and if they start improving the steroids, especially if they have history from before, was the vision normal after the prior episodes, all these things come up. Do you want to add?
I would agree with that. The steroids are the foundation around which we treat optic neuritis. Sometimes you need to give more for some people than others, and although 3 days is the standard, I've certainly treated some people twice as much, depending on how severe their optic neuritis is or whether they seem to be getting better and then got worse again. I will certainly give steroids longer if I feel like I need them more. And rarely, in extreme cases where a patient has gone completely blind and where we want to basically throw the kitchen sink at the disease, we will either wash the blood with something called plasmapheresis, where you get hooked up to a machine that filters out the antibodies we think are causing inflammation, or give an infusion called IVIG, which also kind of achieves the same end without having to do that sort of surgical procedure. Neither of those treatments really, those are sort of Hail Mary passes, and there are studies that show they work, and then there are studies that show they don't work, and so I don't think we have enough experience to know whether we're sure that they're going to help any given patient. But in the setting of blindness, you feel like you really should go all the way. The majority of patients with optic neuritis do very well with a standard run of steroids, and the pain goes away quickly and the vision improves much, much quicker if you get steroids than if you just wait for it to get better. So it is true that optic neuritis will recover, but most people don't want to stay blurry any longer than they have to, and so giving the steroids is usually a pretty popular option.
Yeah, right. And also, just to highlight that if the vision loss is so severe, let's say a person cannot see anything, the first question to ask is this really a simple, like straightforward optic neuritis? It's not. That's one of the definitions of atypical. And then there are other diseases to consider. So it's not necessarily MS, it could be something else. Most patients, even in the long term, should not go blind from MS. Most people do very well from a vision standpoint. Although quality is a different thing, I'm talking about the reading vision and those things. Mm-hmm. Most patients with MS, at least in my, they should not become legally blind. Then you have to say, is this something else? Or rarely we do see that people can have two coexisting conditions. Now, these are the things that somebody is not thinking about, right? Again, as I said, it's just standing back and saying, is this, if it's not behaving the way I expect it to behave, what else is going on here? And then you got to think about a combination, those things we see as well. They're not common, but because the scenario is uncommon.
Okay. Now, another question I just thought about. Oh, sorry.
General question. You two doctors basically have touched on every aspect of my question. How difficult is it to distinguish optic neuritis from vision problems? How difficult is it to distinguish? Where would you start at if you begin to have vision problems? Do you start with most difficult, or do you start with the easy fix, vision problem?
You're asking about diagnosis or treatment?
Diagnosis, just figuring out what is it.
Why are they blurry?
Right. The diagnosis depends on who you're asking, right? So it's primarily, right, doctors in general can also be biased based on what they do, right? If somebody has some pain and some tightness, if you go to a rheumatologist, which is a joint specialist, he is thinking the patient has arthritis, whereas it could be from MS. I'm just telling you, doctors have such biases. If you go to a doctor who's used to seeing a problem inside the eye, he's thinking of that, and there might be a little bit of delay. Those things can happen. And so it's a kind of a very broad question. In general, we say it is a clinical diagnosis, meaning that if everything is done perfectly, if the patient's story, right? So there are two aspects to diagnosis. One is the doctor's exam, but how the patient tells you the story. 80% of the diagnosis is in the story, it's in the history actually, in most of the neurological disease. And so if you listen properly and then use the appropriate diagnostic tests in the clinic, with a reasonable certainty, you might be able to tell that the patient has optic neuritis. So the only reason to do an MRI with a typical optic neuritis is to see if they have a risk of developing MS in the future if they don't already have MS. You don't really need an MRI to tell somebody has optic neuritis. So it's a clinical diagnosis.
And speaking as a non-ophthalmologist, Dr. Narayana is a neuro-ophthalmologist, so he really knows what he's talking about. But when you don't, and you're not an eye doctor, I can tell you that there are things you don't want to miss. And as a neurologist, when someone comes to me, my MS patient says, my vision isn't right. There's things I don't want to miss, but I also know I'm not going to be able to diagnose. And so I am very quick to say, you're having an eye problem, and there's a lot of eye stuff that I don't know how to diagnose, and so I want you to go see an eye doctor. It may not have to be a neuro-ophthalmologist in the beginning, but I want to make sure that I'm not missing a hemorrhage in the eye, or a glaucoma, or a cataract, or a retinal detachment. There's all these things that no one should miss because they're fixable, they're treatable, they're curable as long as you make a diagnosis early enough. And so you're right. I mean, somebody who knows what they're doing needs to look inside the eye, dilate the eye, look in the eye, and rule out glaucoma, cataract, hemorrhage, detachment. And then if none of that stuff is there, and that's all easy, by the way, a regular optometrist is trained to recognize those diseases. If none of that applies, then you start to really, dig deeper and say, is this optic neuritis or not? And that's where neuro-ophthalmology becomes involved, or sometimes not. Like he says, if the story is very classic for optic neuritis, I may feel comfortable treating optic neuritis once I know that the general ophthalmologist has said it's none of these other things. And so that's usually the way a non-ophthalmologist would approach that question.
Wait, need to find out, when do you classify a patient having a relapse, my thinking because of optic neuritis, and in that result they're having pain or issues with the eye and inflammation, and the patient's going to get prescribed pill prednisone eye drops. So I guess I'm relating steroids to a relapse in some form or another. But it's never classified as having the optic neuritis reaction. It's never classified as a relapse. Or is there any situation you have a relapse because of the problems with the eye?
I think you're like maybe 5 questions bundled in there. Okay, but we'll answer all of them. Okay, that's excellent. Yeah, so I think if you need to use drops, if an eye doctor thinks you need to use the drops, that's not optic neuritis. or at least in the sense that we are talking about. It's some inflammation in the front part of the eye. Okay? So you can have a different autoimmune problem inside the eye, not necessarily in the optic nerve, and that's called uveitis. And interestingly, uveitis also can occur in patients with MS, although rare, but it can occur. And so if somebody tells you to use drops, more likely that it is not optic neuritis. It is more to do if you have light sensitivity, pain with the eye, more severe light sensitivity, that's more of inflammation in the front part. So that's the drop part. The other question you're asking is, how do you say somebody has a relapse? In general, it's the same rules for relapse of MS. So you should have the symptoms of optic neuritis lasting more than at least 24 hours. Okay? And the classic symptoms are reduced central vision, some changes in the color vision, pain and eye movements. Okay? And that should be mentioned by the patient as well as be seen on exam most commonly. We also examine the pupils very carefully, and the pupils react differently in the eye that's having optic neuritis. So we use those combination of things and we look at the optic nerve, how it looks. If it looks inflamed, if it looks swollen, right, which occurs in about 1/3 of patients, and then you have a very classic thing. Even if the nerve does not look swollen, which is 2/3 of patients, which is the majority, but if you have those symptoms in the appropriate clinical setting, that's what the doctors use, meaning that in the exact type of situation, right? If you have 79-year-old person with a badly controlled diabetes, I'm not thinking that's optic neuritis first. It's very likely to be an infection. Okay? So depending on the patient's age and their story, how they are developing it, that's how we make the diagnosis. Now sometimes if they already had one optic neuritis and some baseline vision loss, it is difficult to prove, then we may have to get a visual field to prove that it is worse than before, to say there is really a relapse. This point is important because people who have had optic neuritis in the past, if they get dehydrated, for example, or if they are exercising, they can have very short lasting, 10-minute, 20-minute lasting symptoms in that eye, but that's not necessarily a relapse. It's called a Uthoff's phenomena in MS world.
What is it called again?
Uthoff's phenomenon. Uthoff. Uthoff. It's German, but yeah, Uthoff.
Good morning. I was diagnosed with optic neuritis in 2014. And since then, the glasses that I have on is probably the third prescription that I've had since then. I've had an MRI last month, and the doctor at Shepherd Center, she told me that I had to do 3 days of steroid IV because she says that there was a lot more lesions on my brain than the last MRI prior to that in October. So I'm supposed to have another MRI in next month. So I wanted to find out because sometimes I can see better without the glasses, and sometimes I take it off because with and without the glasses, it's like I don't understand what the glasses is doing because sometimes I have to, if I'm trying to see something on the television in the guide, I have to ask my daughter to look at it and tell me what it says right there. So I'm still trying to figure out, okay, how is this glasses helping me? So I guess I'm going to have to come in to see you to see if you can help me.
That sounds like a very good idea.
Well, what I am able to tell, not in your case, in general, like if you come, let's say somebody comes to see me, is which part of that is the nerve issue and which is not. So that sorting that out is useful. So I'll make very generic comments. So we talked about the curvature and the lens being clear, right? So the focus, improving, maximizing the focus is the job of the glasses. So it's important to make sure that you don't have any problems with the focus. Now, I want to mention this to you that there are conditions in the cornea, for example. If somebody has astigmatism, you might have heard of that word, right? The curvature is not equal, it's irregular. There are disorders of the cornea, and all of those can mess up the focusing power of the eye. It's an entirely different problem. It's got no relation to MS. Those kind of things can be present, okay? And then somebody can have dryness, which is an easier problem to fix. So all those things are in the forte of optometrists and ophthalmologists. Okay? But if somebody has a problem, an additional problem, if you have combinations of these, you can imagine that the quality of vision might suffer a little bit. It is also common if somebody who has had optic neuritis in the past, the nerve is not conducting perfectly. So if you have dehydration in general, if you don't get enough sleep, if you're fatigued or tired, if you get an infection, for example, or depending on the illumination, your vision can fluctuate. So that's very well known.
Okay, thanks. Okay, we do have some questions from our social media followers. And start with this one. I think this will be a good one. There's a lot of talk about the use of medical marijuana. Can you address that as it relates to MS?
Yes, I'd be happy to. So you look like you had a little, something else to say. Okay. So the topic of medical marijuana is obviously all in the news, and it's a very political one. And as you're aware, different states have addressed the law quite differently. But the science is an evolving topic. Marijuana does not do anything to address the primary problem, the immunologic problem. So it's not a disease-modifying therapy. It doesn't reduce the risk of having a relapse or the risk of progressing your disability. But it does address some of the symptoms of MS. So, long ago, I think one of the early indications was an eye indication. Glaucoma, I think, responded to medical marijuana in some form or fashion. Optic neuritis, to my knowledge, does not. But a number of patients have found that medical marijuana, or THC, which is the chemical the chemical part of marijuana that has a biological benefit, seems to help pain, and it seems to help spasms. It seems to help tremor, and in some patients it can help with mood and fatigue. So there are some benefits to this in selected patients, depending on how you respond to that drug. Now, some patients feel that it makes them feel worse, and some people feel that it makes them feel better, but that's true of any drug. THC is a drug, and it was an illegal drug. Now it's a semi-illegal drug. In this state, they've passed a law that allows you to possess a certain amount of THC, not marijuana, but THC, legally, if you get a card, but they have not provided any legal mechanism for you to purchase THC in the state. So it's kind of a catch-22 right now. In terms of my own personal practice, we really haven't figured out how best to use this because we're not in a position to prescribe it or kind of manipulate it in the clinic. And so I think once it is fully legalized, then we'll have a better opportunity to know what it's good for and what it's not. Right now, I have probably about 20 patients who have gotten their card, but I don't exactly know how they're getting their THC.
My role and answer to that question is easy. Neuro-ophthalmologists mostly are diagnosticians, so I don't do any prescribing. But just to answer from a vision standpoint, I don't think there is any clear proven benefit from the literature. And I don't know if any of my ophthalmology colleagues actually prescribe it for any specific indication. So right at this time, probably the scientific evidence is still kind of coming in.
Okay.
We have another question from the audience.
Okay, my question is, you mentioned that it's THC that helps medically. My understanding is that it's the CBD. So which is it?
It's the THC is really that's the biologically active agent. CBD is legal, so you can get CBD right now without a prescription over the internet, and many patients claim to feel that they feel better on it, but there are no medical studies that show that CBD helps MS. The one where most of the research is going is going to be.
What does CBD stand for?
Cannabinodiol, I think, is what it is. It's the marijuana plant when you break it down into its components, there are lots of different chemicals in marijuana, just like in tobacco. You know, you have tar and nicotine, and I would liken it to CBD being like the tar and THC being like the nicotine, you know. But you can get CBD legally, and I do have patients who have experimented with it and swear to me that they feel better. And I've never argued with a good placebo, but I don't think that there's a true biological function to CBD that's worth the money. This is not cheap. So these, you know, you can buy it, but it's I think a bottle of CBD is going to run you somewhere north of 125, 150 bucks. So it's not that cheap.
Okay. Next question. Is Devick's disease the same as neuromyelitis optica?
Want me to take it?
Yeah, you go.
Okay. Yeah, it is the same disease, and long time ago it was believed to be more severe MS, but I think, or a cousin of MS, and we understand more and more about the disease now. There are diagnostic criteria that as we learn more, there is new definitions and new criteria being added on. There is a blood test available for this condition now, but there are patients who can be diagnosed even without the blood test. And when we say the word neuromyelitis, so there is the optic nerve involvement as well as the spinal cord involvement, so that gives you the idea which parts of the nervous system are involved. And so, as the name itself says, the vision is quite frequently involved, and just relative terms, prognosis-wise, the NMO or the Devick's disease tends to have worse prognosis overall compared to MS.
It wasn't that long ago, though, that that NMO was really discovered. We've called it Devick's, you know, for 50 years, thinking it was part of MS, and it's probably been a decade that we've now had this blood test, maybe even less. I think they discovered it at the Mayo Clinic. But even now, I mean, there are patients who are still being called multiple sclerosis who we're discovering actually have NMO, and you know, this we'll probably have a case or two a year where we're having to re-diagnose them with something other than what we thought they had. So it's a very much an important distinction, because they're treated with different medications. And it is a simple blood test, and when you have that blood test, it's pretty clear that it's NMO, but unfortunately, as Dr. Narayana says, you can have NMO and not have the blood test. So anyway, it's tricky, but those are the same thing.
So we have a few more questions from the audience. One that to circle back to marijuana.
I'm gonna let you take this.
I was just wondering if you take the CBD, will it show up positive on a drug test? I do HR, so you know.
You know, I actually don't know the answer to that.
I don't either.
You know, I don't know the answer to that.
I think it does, probably, but I'm not sure. I don't know.
I think the drug screens are checking for THC, but please do not quote me on that, and don't go to work, you know, with a bunch of CBD in your system, you know. So I honestly don't know, but I bet you the answer to that is online.
I think Google Doc knows that.
Yeah, Dr. Google, we'd all need to go for that.
And then we have another question. Yes, is there some debate over whether you should continue to treat patients after a certain age with using modified therapy after 66 or 65? Is there debate about that?
So this question of stopping treatment after a certain age has become a very hot topic, and in fact, you know, docs in my world are sort of squaring off over this, because it's a very passionate conversation about whether you reach a point where either your immune system is no longer active enough to cause MS, or you're too old for it to matter, you know. I mean, and these are, you know, these are the legitimate issues that are being sort of sorted out. Is, are we just throwing good money after bad? If you're 70 and you've got MS and you're in a wheelchair and you're still taking your injection or your pill or your infusions, is it worth it? It is not resolved whether this is a good idea or a bad idea. To some extent, unless you're dead, there is always something left to lose. And if you're quadriplegic but your mind works, you could lose your mind, or your vision. And the immune system in elderly people is still a functional immune system. So it is still capable of fighting off infection, fighting off malignancy, and causing autoimmunity. So it is capable of doing all those things. It is true that the older you are with MS, the less likely you are to have a flare. But it's not, I treat elderly people with flares all the time, and so I know that it's not uniformly true that all 70-year-olds with MS should come off medication. When you start to figure out, well, who should and who shouldn't, I don't know how to do that. I know that stable patients on therapy may well be stable because they're on therapy. And the only way to know that they don't need therapy is to stop it and see if they become unstable. I haven't had a lot of patients volunteering to do that, but it's a legitimate argument in the neurology community, partly because our medicines are so very expensive and because elderly people have other diseases that they're trying to deal with as well, and sometimes the medicines that we want to give you interfere with the medicines that some other doctor wants to give you. So it's a great question and very much a hotly debated topic. It seems like it's really kind of emerged in the past year or so, that experts are kind of coming to the journals and arguing in favor or against stopping medicine.
I think from the vision standpoint, there is other group I just mentioned, the autoimmune disorders, the uveitis. There is some evidence, not necessarily from studies, but at least expert opinions, where people think, as Dr. Stuart is mentioning, after 55, the disease tends to die down on its own, and that's where this question of, is it necessary to treat long term, etc. But probably it's more of a socioeconomic question, and I think it should be individualized. Probably it's a tough one. Yeah.
Okay. One more. Okay. Question for you, Dr. Stewart. Can you talk about MS hug? What is it and how it's treated?
The MS hug. So this cute name kind of emerged to describe something that's not so cute. So an MS hug is a feeling of squeezing, like you're being hugged around the chest. And they call it a bear hug because it feels like what a bear would do. Now, this is not a teddy bear, but maybe more like a grizzly. And it's a painful squeezing around the chest or abdomen that reflects demyelination in the spinal cord. So it's caused by an area of MS that's affected the spinal cord, and at that level, the nerves typically wrap around the body. So the nerves come out of the spinal cord at that level and wrap around, following the course of the ribs. So, ribs kind of go from the back and wrap around to the front. So do the nerves, and that's why the perception of pain is sort of a wrapping around pain. We call it an MS hug. It's uncomfortable, but usually it's treatable with steroids or with some medicines that we use for nerve pain, and usually it's treatable, but it's not a lot of fun. Anyone here had an MS hug? We've got a lot of hugs there. Okay.
Okay, this is for you, Dr. Narayana. We've kind of touched on this today, but can you kind of define the difference between ophthalmologists, optometrists, and neuro-ophthalmologists?
Okay. Yeah. So ophthalmologists are basically doctors who go to medical school. So the broad training, so the way the U.S. training, although I didn't do my medical school in the U.S., but the medical school gives you and I'm sure you can chip in, is the very broad training of the entire body, right? And then you can choose to specialize through residency any particular area that you want to do. For example, somebody can train in the medical field and become a neurologist specializing in the brain, or you can specialize in the eye, which is the ophthalmology. So ophthalmologists are medical doctors who are trained. Ophthalmologists also typically are able to treat even surgically. So most of all of the ophthalmologists are trained in surgery. So they can do cataract surgery, LASIK surgery, retinal surgery, other surgery, glaucoma surgery. So anything to do with the surgeries they can do. So that's the broad information about ophthalmologists. Right? An optometrist, the training is, they don't have the broad training in the medical school, although in their curriculum they do learn about the other parts. They haven't had the broad training through hospital training of the entire human body. So their training is more restricted to the eye-related training, but so they are not surgically trained per se, although the scenario is changing. There are optometrists now who are doing laser treatment, not the actual full-blown OR surgeries, but they are doing some laser treatment. So there is a lot of overlap in what they can do, and it is usually also related to the individual skill and comfort level is one. The second is the regulatory scenario in each different state that can also be variable. A neuro-ophthalmologist is a slightly different animal, and so neurologists or ophthalmologists, any of them can train through a fellowship. A fellowship is a subspecialized training after your residency, which can span 1 to 2 years of the training. So in the US, you can be a neurologist and train to become a neuro-ophthalmologist, or you can be an ophthalmologist and train to become a neuro-ophthalmologist. And actually, very interestingly, it's 50-50 in the US. There are about 500 to 550 neuro-ophthalmologists in the country, and that's the division, 50-50. And there are a few of us who are trained in both. I did have ophthalmology training abroad, and I did neurology training in the US. There are some of us like that also. So what neuro-ophthalmologists particularly do, if you go back to that first slide, maybe we can just very quickly, so any problem within the eyeball, it's the optometrist and ophthalmologist. So if it is a disease per se, so the focusing issues, the glasses, contact lenses, optometrists are extremely good. That's what they do all day. Diseases within the eye is ophthalmologist, and the nerve and beyond, and also other problems. For example, if you have double vision, so the eyes are normally, if you go between the two eyes, you see that you're focusing on the same object slightly off, and that's what gives you the 3-dimension. But the eye coordination of the two eyes moving together, whichever way you go, is from the brain. So the eye movement is not a function of the eye, it is from the brain. If you just push your eye a little, you can do this on yourself, you start having double vision. So double vision issues, eye shakiness, nystagmus, nerve problems, stroke-related vision problems, MS-related vision problems, tumor-related vision problems, all of those are in the forte of neuro-ophthalmologists, and primarily their job is diagnostics, meaning that the eye doctors don't say, and we say localization, vision-related. So neurologists have already seen, ophthalmologists have already seen, and they send to us, and we are trying to figure out where is the problem. That's the first step, is where. And then based on the patient story, then what is causing it. So it's primarily diagnostics, but then depending on their training, if they're ophthalmologists, they can do some part of the surgery as well. So that's the broad differentiation.
We're going to take one more question from the floor, and then we're going to wrap up.
Hi, I wanted to get some information on the stem cell treatment and MS. How does the two relate?
Stem cell treatment.
Okay. So the topic of stem cell treatment in multiple sclerosis is another one that's kind of a hot topic of research and around which we don't yet have very good guidelines. First of all, what you need to understand is that there are different types of stem cell therapies, and they're not the same. Even though we use the same word, they're not the same treatment. So for instance, there are stem cells that you can get from fat tissue, like you can take it out of the fat pad of your belly or other parts of the body. And those stem cells are only capable of becoming, certain types of immunologic cells. They can't become nervous system tissue. So you can't regrow damaged nerves from that or regrow myelin from that. You can only downregulate the immune system. And you can't do that very well based on where we are so far with that technology. So that we call it mesenchymal stem cells. There's a little evidence that it helps a little bit, but it's not a very dramatic therapy. A much more dramatic therapy is something called hematopoietic stem cell therapy. And the other term for this is bone marrow transplantation. So, we're used to hearing about bone marrow transplants for cancer victims, especially leukemia patients, but other kind of solid tumors, we will often do what's called a bone marrow transplant, where you take bone marrow out of the patient and you save it and you treat it so that you've tried to get bad cells out of the bone marrow, and then you give the patient chemotherapy to knock out all the rest of their bone marrow and their white blood cells, and then you re-implant the bone marrow that you harvested, hoping that the bad cells are gone. And in multiple sclerosis, what you're hoping is that when you regrow a new immune system from these sort of bone marrow seeds that you're going to reimplant, you're hoping that the new immune system is not prone to MS, that you've kind of killed off the immune system that causes MS and your new one doesn't cause MS. So you're hoping that that's the case. And in fact, there's a trial called the HALT-MS trial where they've done that in a limited number of patients, and it looks to be very effective. To call it a cure for MS is premature, but the results in terms of reducing relapses and progression of disease were so dramatic that I feel sure we're going to see a much more extensive study of that therapy. Now the problem is it's a dangerous therapy. We've gotten accustomed to treatments for MS that are really very safe, and very tolerable, and don't require very much of you, and very, very effectively reduce relapse frequency and disease progression. This therapy is not easy. It involves hospitalization, often for several weeks, while you're waiting for your immune system to recover. And there's a significant risk that the therapy will end up in the patient losing their life. So we don't go to this yet on a regular basis because A, it's risky, B, it doesn't seem like we're quite there yet, and D, insurance companies have not yet viewed this as an FDA-approved therapy for MS, and so they don't pay for it. I've had some patients go to other countries and pay cash to have it done. It cost about $50,000 to get it done in Mexico City. I had a patient go to Moscow. I've had a patient go to China. And I don't love it when you go to another country because I don't have any way of knowing whether you're really getting the therapy you're being sold or not. The third type of stem cell therapy is what's called a pluripotent stem cell transplant, and in this case, we hope one day that we'll be able to take these sort of primordial cells that can become anything and put them in the right context. And let's say you have an area of your brain that's scarred up and you've lost brain cells. Maybe we can regrow those brain cells. Maybe we can regrow those spinal cord cells. And so we're hoping that one day we can practice what's called restorative medicine, where you take somebody who's lost stuff and you give it back to them. Much as you can transplant a kidney, you could maybe transplant brain cells or spinal cord cells. There's a long way to go on that one. That's the one that's probably the furthest away. And I think, I don't know how far away this is. I doubt seriously it'll be in my lifetime, but that's the other kind of stem cell transplant. And it's probably the type of stem cell transplant that most patients would be interested in who've lost function, patients who are in a wheelchair or are blind or have lost their memory. They want it back. And the bone marrow transplant isn't going to do it, and the mesenchymal stem cell transplant isn't going to do it. But maybe down the road, a pluripotent stem cell approach might help.
Okay, thanks. Are there any other questions? Any additional comments from the two panelists?
Yeah, just with the stem cell, the same thing, just in terms of the vision, they've been able to grow some of these cells. For example, the cells in the film that I said, the retina. Retinal cells, they've been able to grow in a petri dish. They form a ball instead of being the flat surface, and they don't talk to each other. So anatomically, or just you're able to make those cells, but you're not in a position to make them talk to each other, where you have to send the signals. So it is very close, still very far, as you said. So we are there, but we are not there. It's not been successful, and please don't spend that 50,000. It's not proven anywhere, and it can be dangerous. And there are patients who have died, and that's the alert.
That's true.
Yeah,
That is true.
So let's give a round of applause to our panelists. And